Thank you very much. I pay my tributes to my alma maters and my thanks for nice introduction. And I thank Evopian organizers and my mentor at AIMS New Delhi, Professor Shefali Gulati, for giving me this opportunity. The topic for me is newer anti-seizure medications, indications, and contraindications. And I will try to cover as much as possible in 20 minutes. I understand there is a mixed group of audience today, ranging like starting from pediatricians, pediatric neurologists, maybe adult neurologists. So trying to do justice for everyone. So this is the outline of my presentation. So we will know what are the new anti-seizure medications, why do we need them, and what are the so I will be dealing with some of the few newer anti-seizure medications with case-based discussion and maybe a touch upon repurposed anti-seizure medications, and then we'll conclude. Organizer, like kindly let me know 5 minutes before the time closes. So what are new anti-seizure medications? We know bromide was an anti-seizure medications which were introduced way back in the 19th century. And from after that, there was a long gap of nearly 60 years until the modern anti-seizure medication phenobarbital arrived. And phenytoin was introduced in 1940s by Putnam and his colleagues. So since then, there has been an explosion of anti-seizure medications. So these are categorized as first generation, second generation, third generation, based on their mechanism, their efficacy, their class variations. So you can notice from like the new millennium onwards, at least in the last 20 years, there has been an explosion of newer anti-seizure medications. At least 30 molecules are there already in market, and 30 molecules are being under development. But why do we need a newer anti-seizure medication when we have so many anti-seizure medications already in the market? That's because when you start anti-seizure medication for a person who is newly diagnosed with epilepsy, that renders the patient seizure free only in 46%. This is based on long-term multiple studies. And 54% of the patient, despite being on an optimal dose of one anti-seizure medication, remains uncontrolled. So in those 54 patients, if you try a monotherapy of another agent or as a combination therapy of another anti-seizure medication, the seizure freedom rate in that 54% is only 12%. So it's not like 60% of them get controlled. Only 12% of them get controlled. Remaining 42% remains uncontrolled. So in this subsequent subsets, having tried two medications, addition of any other new anti-seizure medications, a third agent or a fourth agent, even sometimes fifth agent, sixth agents, does not give very high seizure freedom rates. You can notice that it's only 4%. That means out of 100 patients who have not been controlled on two anti-seizure medications, if you try a new anti-seizure medication, the chance of them becoming seizure free is only 4. Only 4 of them can become seizure free. So that's the need. Like you need to have a molecule which is having good efficacy, who can be controlled of their seizures despite having tried conventional anti-seizure medications. At the time, they should have a better side effect profile and other advantages as well. So before this, I just want to bring into one concept, like the terminology for an anti-seizure medication, anti-epileptic drug has been changed to anti-seizure medication. The correct terminology according to ILAE to address a medicine which controls or suppresses seizures is anti-seizure medications, because the medications currently used in the treatment of epilepsy exert a symptomatic effect on against epilepsy. They control epilepsy. They don't cure epilepsy. That's the reason they should be referred as anti-seizure medications. So with this background, so when we talk about newer anti-seizure medications, of course, they have better tolerability, lesser side effects, minimal drug interactions when compared to first generation or second generation agents or conventional anti-seizure medications. But there are some disadvantages as well. For example, they may be having higher cost. There may be an availability issue. Suppose there is a new anti-seizure medication which is introduced into the market, but you are not sure whether it is available or whether it is available for a longer period or extended period of time. But coming to one of the most important parameter in terms of efficacy. So are the newer anti-seizure medications truly having higher efficacy when compared to the conventional medications? That means, do they render the patient seizure free, higher seizure freedom rate, either as a monotherapy or as a combination therapy? Yeah, that's questionable. Let's see in our subsequent slides how it goes. So there are several new anti-seizure medications, more than 30. It's not possible for me to cover everything in this, but I will try to touch upon and give you an overall understanding of some of the important newer anti-seizure medications, which a pediatrician and a young carrier pediatric neurologist should know. So let's start with case one. This is a 5-year-old boy who presented with mild development global delay, and he presented with status epilepticus to the ER, and he was loaded with IV levetiracetam. He had recurrent episodes of unprovoked focal seizures. It's focal seizure. And his MRI was non-lesional, and his EEG was suggestive of a focal abnormality, left frontocentral epileptiform abnormality. And after IV loading with IV levetiracetam, his seizures got controlled. On 2 months follow-up, his seizures were well controlled. In a patient with epilepsy, it's not only seizure control which we are looking at. We are also looking at the quality of life, and also the patient should be devoid or having minimal side effects and tolerating the medication well. But the parents complained of significant behavioral issues, irritability, and aggression. So that's significant. That's an important concern for the family. So what best can be done as a next step in this situation? So the participants can put in their chat box if they want to. So option A, you want to reduce the dose of levetiracetam. He is already on lower end of the required dosage. Option B, some people add pyridoxine. Option D, you may try antipsychotic medications. Option D, do you want to switch over to a newer anti-seizure medication? Yeah, let's think about this. In this situation, this patient has been controlled with one anti-seizure medication of one class. So the problem here is only the side effect. It's not seizure control. So I would like to try switch over to a medication of the same class, but that is devoid of this behavioral side effect. So that's how my thought process comes in this situation. But do we have an agent like that? Yes, we have one agent. That is brivaracetam, which is a newer molecule, like a congener of levetiracetam derived from pyracetam. This acts on SV2A ligand, and this is highly selective. So brivaracetam is a newer molecule which is 30 times more potent, has more affinity to this molecule. It is more efficacious, but at the same time, it is devoid of the side, or you may say it's having only minimal side effects with respect to behavioral issues. So if you start 100 patients on levetiracetam, 10% may be in 10%, the side effects of behavioral side effects may be significant enough, necessitating the cessation of medications. In those patients, if the drug was working well in terms of seizure controls, a better option is to switch over to an agent like brivaracetam. So the switch over is very easy. It's just 10:1 ratio. If the patient was on 500 milligram of levetiracetam, just switch over to 50 milligram. It's a direct switch. No need to taper and slow starting. It's a direct switch. And you can see if the patient was uncontrolled on levetiracetam, even in those situations, 1/3 of patients may respond to brivaracetam because of the better efficacy, and 1/5 can remain seizure free also. And in patients who had side effects, which is intolerability to levetiracetam, 64% can become side effect free. So in that patient, we switched over to brivaracetam, direct switch, 10:1 ratio, and the patient was doing well, seizure free, and also he did not have any much behavioral side effects, and the parents were happy. And the cost and availability of this medication is also not a big issue in current scenario in India. So brivaracetam has been approved by FDA for focal onset epilepsy in children aged 4 or more. Although IV preparations are available, the safety has to be established as per the latest guideline from FDA. It does work in generalized epilepsy as well, but currently it's approved for focal epilepsy in children. We do use for as an off-label indication in generalized epilepsy as well. There are no major contraindications except for hypersensitivity to the drug or inactive ingredients. No major adverse events or no major drug interactions. Available both as a syrup as well as a tablet. So practical tip for pediatric neurologists who are dealing with difficult to control epilepsy. So we struggle to deal with patients who are having MRI negative drug resistant focal epilepsies. In a setup where invasive kind of monitoring is not possible for a patient to undergo pre-surgical evaluation, try at least one SV2 modulator like a brivaracetam before you refer them. Before we kind of exhaust all our options, while in the meanwhile we evaluate for the possible surgical options. That's not true for MRI lesional cases. I'm talking about MRI negative cases. Coming to the next case, case 2, this is a child with type 3 Gaucher disease. He is already on ERT, enzyme replacement therapy. He presents with nearly continuous multifocal myoclonus to the epilepsy clinic, and he also has bouncy gait because of the myoclonus. He has been tried on multiple anti-seizure medications. He has failed valproate, clonazepam, levetiracetam, pyracetam. All these medications are for the myoclonus part. Gaucher and lysosomal storage disorders can present with myoclonic phenotype. I will show the initial part. Yeah. So that's his myoclonus. So we all know enzyme replacement therapy works very well for the visceral form of the disease, but not from the neurological form. It may stop the progression, but whatever symptoms the patient already has is not reversed by the ERT. So you need to manage them symptomatically. What next can be tried best in this patient? Keto diet. Yeah, there are some evidence for keto diet in lysosomal storage disorders, particularly in Gaucher. Any newer anti-seizure medication can I try? VNS, vagal nerve therapy, which is highly expensive for such families. He's already getting ERT on a compassionate basis. Steroids, no much role. So this patient, we started him on a molecule called perampanel, which is an AMPA receptor antagonist. We know anti-seizure medications act on several targets, ranging from ligand-gated channels, voltage-gated channels. Majority of them act on GABA or sodium channels. This is the only anti-seizure medication which acts on AMPA. AMPA is an excitatory neurotransmitter. So by inhibiting AMPA, you can limit excitation and thereby restoring the balance of inhibition and excitation, which is one of the core reason behind epileptogenesis. So this patient responded very well. There was more than 50% reduction in his myoclonus. That's what the family was like. In terms of the progression of the disease, the family was very much satisfied with the progress of the ERT as well as his symptomatic management. So perampanel is a novel agent acting on AMPA, has been approved for usage in children with partial onset epilepsy with or without secondary generalization 4 years or more, and also for generalized in 12 years or more. Rarely we do use off-label in generalized epilepsy under 12 as well. So one important scenario or common, a good subset of population where perampanel can be tried very well is those who are having focal onset refractory epilepsies with secondary progression to bilateral tonic-clonic. This population responds very well to perampanel, and also myoclonus also responds very well to perampanel. There are no contraindications according to FDA label, and the caution is exercised in terms of in patients with psychiatric illnesses, particularly suicidal ideation is one. In adolescents is one need to be very cautious about. Case 3, this is a patient from Canada, and this is from internet, from Dravet Syndrome Foundation. This is a girl child with Dravet syndrome. She experienced up to 200 mini seizures a day. 200, that's massive. And she has been tried about 10 anti-seizure medications from her lives, all conventional, sometimes even some of the newer as well. So the family found out a new medication, and they started this medication after prescription from a doctor. And from the impact of this new medication, according to the family, has been profound. For as many as 200 mini seizures a day, she came down to 15 and only one large seizure a week. And that impact has been profound, according to the family. So that drug is fenfluramine. This is the current consensus guideline for Dravet syndrome. So, of course, we avoid sodium channel inhibitors. The first line is being the conventional agent, broad spectrum valproate. And then we have 3 agents which can be tried, like fenfluramine, stiripentol, clobazam. And if that fails, add on cannabidiol, and like last resort, like ketogenic diet or even VNS can be tried. So fenfluramine is one of the promising option in patients with Dravet syndrome, and this has been approved, FDA approved for Dravet syndrome as well as Lennox-Gastaut syndrome of any etiology. And there is a significant proportion of patients who become seizure-free. More than that, a majority of the patient can become as responders. That means more than 50% reduction in seizure freedom. One need to exercise caution with pulmonary valvular fibrosis. Fenfluramine is basically serotonergic agent, which was initially approved in the last century for as an appetite suppressant, and that has been repurposed and came back as an anti-seizure medication. And currently, it's available only as a special access in Canada, and it's widely approved, widely available in US. Yeah, so we do use fenfluramine in patients who are having refractory seizures, both Dravet as well as Lennox-Gastaut syndrome. Case 4, this is an 8-year-old girl who is having Lennox-Gastaut syndrome. We know Lennox-Gastaut syndrome, the common seizure types of drop seizures and tonic seizures. This patient had numerous drop seizures and tonic seizures. He was already tried on clobazam, levetiracetam, and rufinamide. Rufinamide is one agent which has been prescribed, which is reported to be having good efficacy, particularly for the tonic and the drop attacks of Lennox-Gastaut syndrome. Did not help in this situation. The parents are hesitant to try conventional anti-seizure medications like valproate and topiramate in view of side effects. We know parents go through a lot of resources, both internet and other. There are family support groups also, like LGS groups. So they were not happy with starting these medications in view of possible potential side effects. They were not willing for ketogenic diet and also for any potential surgeries like corpus callosotomy. Parents are okay to try a naturally derived product if it is acceptable. So is there an option? Yes. So we have CBD preparations, that is cannabidiol oil. So cannabidiol, the cannabis extracts contain both CBD and THC. CBD is the anticonvulsant agent. THC is a proconvulsant agent. But you need to prepare, you need to create a formulation which contains very high proportion of CBD, that is anticonvulsant, with a very minimal proportion of THC. So these preparations are available in across the world as artisanal preparations. We don't know the exact proportions of these CBD versus THC, but purified preparations, which is available in US as Epidiolex, has a very clear purified proportion of cannabidiol. And both of them in Canada, as of now, artisanal preparations are available, and its Epidiolex is not available as a free access. So in patients who are having refractory Dravet syndrome, one set of population, highly purified CBD at 20 to 30 milligram has resulted in seizure freedom in around 15%, and you can see the efficacy increasing over a period of time, and significant responder rate is around 40%. So it does work as an add-on agent, and FDA has approved this as an add-on agent in Dravet syndrome, and as a highly purified cannabidiol has been approved for age as young as 1 year of age. So this patient was started on CBD oil, and that needs prescription, and the family has to understand the formulation. So they got an artisanal formulation that did result in a significant reduction, more than 50% reduction in seizure frequency. The patient is on follow-up. One caution is exercise, like one need to be very careful with the formulations, and also if the patient is on other agents which can affect liver function has to be monitored. So FDA has approved CBD oil for Dravet syndrome and Lennox-Gastaut syndrome. Only contraindication is hypersensitivity. So in terms of other newer anti-seizure medications for Dravet syndrome, it's tiripentol. I'm not going into much details of that. One needs to exercise caution that if the patient is on clobazam, that tiripentol can increase the levels of the metabolite called norclobazam. So be careful with the interaction between tiripentol and clobazam. Cannabidiol does not have much interaction with other agents in terms of combination therapy. And as I told you, fenfluramine has no significant interactions with any agent. So that's a suitable add-on agent. So having discussed some of the already existing agents, is there a new promising kid on the block? Let's see. So we know about felbamate. Felbamate is a conventional anti-seizure medications, which has been actually went out of much usage because of the dreaded side effect of aplastic anemia. So a congener, a newer version of felbamate has come as cenobamate, and this has shown a very potential efficacy as an agent, both in focal as well as generalized. As I told you in the previous slides, if you start a patient who has already failed 2 agents, only 4% become seizure free. That's 100 out of 4. But cenobamate trials have shown 21 out of 100 can become seizure free. That's up to 21%. So let's listen to this from Dr. Gross himself. He is one of the co-investigator of the trials.
It's the first one for a substantial number of people who can't get their seizures controlled with any other medicines become completely seizure free. We kind of categorize people as being drug resistant if they failed 2 or more seizure medicines that were, tolerated and they were able to try them. But if you continue having seizures despite treatment with more than 2 seizure medicines, less than 5% of patients become seizure free on subsequent treatments. Now, with cenobamate, it was quite a bit higher. It was about 21% in the clinical trials, and in our extension trials, where we're able to manipulate doses and optimize treatment, it was about 25%. And so that's a significant number. Also, the responder rate in terms of people with marked seizure reduction was 60%. And another thing that was very helpful was there was almost complete control of the grand mal tonic-clonic seizures in these trials. Like, for example, I had 8 patients with tonic-clonic seizures in clinical trials with cenobamate, and all of them, that seizure type stopped.
So that sounds very promising. So cenobamate has a dual mechanism of action. So when we talk about anti-seizure medications, the mechanism of action matters. So it increases GABA as well as inhibits sodium channels. And it has been approved for focal onset epilepsy in adults. And it's currently very expensive, and it is being tried even in patients who have failed VNS and epilepsy surgeries. And there are various phases of trials going on for generalized as well as in pediatric usage. I wish this drug has been proven to be efficacious in very refractory epilepsies in pediatric patients as well. And you may see soon cenobamate getting approved for pediatric focal epilepsies as well. So yeah, so only caution is familial short QT syndrome, because it shortens QT. So last part of my discussion, just 2-3 minutes. So we talk about novel anti-seizure medications and repurposed anti-seizure medications, just touching upon precision medicine. So precision medicines are the medicines which are not exactly anti-seizure medications per se, but they have been tried in different other medical conditions and may be found to have an effect in a particular genetic condition. So it's precisely used for that specific condition. One quick case, a 2-year-old boy born to non-consanguineous presented with multiple episodes of seizures, significant developmental delay. He presented with multiple episodes of tonic spasms, multiple episodes of infantile spasms, and tonic seizures. And as you know, it's clinically fitting into diagnosis of epileptic encephalopathy. EEG showed a classic modified hypsarrhythmia-like pattern, and clinical exome sequencing revealed GRIN2B, so which is one of the subunit of NMDA receptor. He failed multiple anti-seizure conventional medications, including vigabatrin steroids. We started him on ketogenic diet. The parents were not willing, and we found out from the literature the GRIN2B being a part of NMDA, oral memantine is efficacious. These are anecdotal evidence for that. We know that in GRIN2A it's very effective, but not much evidence in GRIN2B. We started him on memantine, which is a drug which is used for dementia in adults, and it is an NMDA antagonist. And we slowly increase the dose. As we increase the dose, the seizure frequency came down and it stopped. So just to show, the EEG also improved. So it's a favorable response to memantine in a child with GRIN2B epileptic encephalopathy. So we need to understand the genetic mechanism of the disease before we think of a possible precision medicines, because there are, like, you need to exactly understand the genetic mutation. Like this report from AIMS New Delhi has shown a novel KCNQ1 mutation which quinine was not responsive. So before you prescribe a precision medicine, be careful with the mutation variant which you are dealing with. There are so many precision therapies currently available. That's a different talk altogether. So with this, I will end my talk. The ever-expanding selection of anti-seizure medications allows more options to select anti-seizure medications to tailor individual patients' needs, comorbidities, and characteristics. But however, nonetheless, none of these patients are addressing the principle of epileptogenesis. So possibly the era of precision medicine may hopefully address this issue. So with this, I bring my greetings from Toronto, and thank you all.